Hello everyone, this is Dr. Saroj Siddiqui from the platform of UKMLA with DSS, and let's just continue our success course of the UKMLA 2 exam. So in the last lecture we discussed the history taking and the sexual history that needs to be taken in the obs and gyne cases, and we just discussed very briefly about the antenatal part, and I told you that we're going to discuss it in the next lecture. So here is the antenatal history and the structure that we need to follow in the antenatal cases. Okay. So before I teach you what the actual antenatal structure is and what to do in it, let me just give you 2 to 3 different variants and 2 to 3 different cases in which you would have to apply this antenatal structure. Okay. So as you can see on the stem, okay, there would be a lady who would be either 32-week pregnant or 36-week pregnant. Okay, that would be coming to you for a routine antenatal checkup, and she might be having a breech presentation. Okay, so this is one variant of the case. Okay, or in fact two variants of the case, that breech delivery in 32 weeks or breech delivery in 36 weeks. All right. And then there is another case in which there is no breech delivery, and there is absolutely nothing wrong, there is no pathology involved, and the patient is just there for a routine antenatal checkup just to make sure that everything is all right with her and her baby. Okay, so these are the 3 cases in which you would have to apply the antenatal history aspects. Okay, so not a lot of cases that test the antenatal, just these 3 cases. Okay, other than that, very important thing, it may be a combined station. Okay, antenatal history station can be a combined station in which you may have to perform the antenatal examination. Okay, and you may have to uh, check whether or not the delivery is breech, or whether a rotation has taken place and the breech delivery has converted into a normal presentation. Okay, so please expect it to be a combined station in a few of the cases. Okay, and in few of the cases it may just be a basic history taking station, and nothing to do with the examination, and nothing to do with the combined aspect to it. Okay, so yeah, let's just discuss the basic component, and then I'll tell you briefly the management, what to do when it's 32-week and what to do when it's 36-week pregnancy with the breech presentation. Okay, but let's just cover the history taking pointers and the data gathering pointers. All right. So when we begin an antenatal case, after you're done with the introduction and after you're done with the rapport building and the open-ended question and all, okay, the first and the foremost thing that you need to do, it's not the Socrates, it's not the OD para and all, it's basically exploring the current pregnancy. Okay, uh, so if a patient is coming for you for an antenatal checkup, that means that she's pregnant. Okay, and she knows that she's pregnant. Okay, so you have to explore the current pregnancy, and there are 4 different aspects of exploring what the current pregnancy is and how the current pregnancy is going. Okay, and I'm going to discuss all these 4 aspects with you now. The number one, you got to ask about the length or the duration. Okay, and how you're going to ask this, that okay, when was your last menstrual period. Okay, so you can get an idea about the duration of the pregnancy through the last menstrual period. Okay, then you can ask, do you know or are you aware of your estimated date of delivery. Okay, or also known as the EDD. Okay, or you can just ask a direct question that are you aware how many weeks pregnant you are. Okay, so it would be written there in the stem, but you still have to ask it just to confirm whether or not she's actually 32 weeks pregnant, or maybe her last menstrual period was not 32 weeks ago, maybe it was 28 weeks ago. So you just need to confirm the length of the pregnancy. Okay, and after you do that, you got to just ask this question very subtly. Okay, and you can just do some signposting as well, that okay, just want to ask a personal question just to develop a better understanding of your condition. Was this pregnancy planned or was it unplanned? Okay, so this question may also be relevant, okay, when you're exploring the current pregnancy. Okay, so this is what the length is, or the duration. then you should be aware of the red flags that are there in a pregnancy. Okay, and you have to ask them. Okay, like for example, have you had any complications during this pregnancy, like bleeding, pain, or any infection, which means any discharge? Okay, somebody might be having some pain, can be because of pregnancy complications. Somebody might be bleeding, it can be antenatal hemorrhage. Okay, somebody can be having vaginal discharge and signs of infection, so it can be antenatal infections. Okay, that can affect the outcome of the pregnancy. Okay, so you just have to inquire about the complications, okay, that may occur during the pregnancy. Number one, the first red flag. Number two, have you felt any fetal movement? Okay, you gotta see if the baby is moving inside, if the baby is, doing some activities inside. Okay, or if somebody haven't, felt any fetal movement, and if she's 32, 36 weeks pregnant, then there might be something wrong inside. Okay, so you gotta ask that. Okay, have you felt any fetal movements? Okay, and if she says yes, then you gotta say that when did they start and are they still happening? All right, then you got to ask about some systemic signs, okay, that are associated with the pregnancy. Like for example, have you experienced any nausea, have you experienced any vomiting, do you feel tired, do you feel dizzy, or do you feel any unusual symptoms or any unusual worry, like palpitations, like unable to sleep? Okay, so you have to explore the systemic signs as well, okay, that may occur during the pregnancy. All right. So these are the three aspects to the red flags. Any complication like bleeding, pain, or any infections. Then have you ever had like any fetal movements? Did you feel any fetal movements, or did you any feel any movements of the baby inside your womb? Okay, and then have you experienced any nausea, any vomiting, any dizziness, or any unusual symptoms that you may want to talk about? All right, try to explore them. Okay, so, second aspect, first is the length, second is the exploring the red flags. All right, then follow-ups, okay, that and the compliance basically. That are you taking any medications, any vitamin or any supplements? You may have to take folic acid. Okay, you may have to take multivitamins to make sure that your baby is well nutritionally covered. Okay, and then you got to ask that, have you had any recent infection or exposure to illnesses? Okay, that speaks a lot about the outcome of the pregnancy. If she has had any recent infection, then you may have to think about antenatal infection and the effect it has on the baby, the risk of premature delivery, the risk of miscarriages. Okay, all of those things, you would have to think if a patient is feeling anything like this. Okay, so any medications, any past infection that the patient may have. Okay, and then have you had any ultrasounds or prenatal test done? So there are some diagnostic antenatal tests, CVS, like amniocentesis. Okay, there are few ultrasound scans. There is CTG. There is Doppler ultrasound. Okay, and multiple tests that are available to check the fetal well-being. So you got to ask about that. Okay, have you done anything like this, or have you done any diagnostic tests like CVS, like amniocentesis? Okay, so just to get an idea that where she currently is at her pregnancy. Okay, in terms of the health, in terms of the duration, in terms of the medical aspect, the follow-ups, the nutritional things that needs to be taken care of during the pregnancy. Okay, so it's very very important to cover this particular aspect. Then the fourth aspect is you talk about vaccination. That have you ever received tetanus immunization? You know that it's important in pregnancy. Okay, if the patient haven't had any tetanus immunization, you gotta make sure that the tetanus part is covered. Okay, then have you ever been vaccinated against rubella, hepatitis B, or COVID-19? Okay, we just need to have the diseases that are commonly transmitted from the mother to the baby in our mind. Congenital rubella syndrome in a baby is something which is a very common complication in women who are not vaccinated against rubella. Okay, and then have you ever had any recent infections, any torch infections? Like very very important thing, as a doctor you should be aware of the torch infection when you are dealing with pregnant women. Okay, so it's kind of like a lot of questions. Okay, and they are just like multiple aspects to it. So I've tried to divide it into four different categories, so that you automatically know that okay, if I have to explore the length of the pregnancy, I'm going to ask about the last menstrual period, I'm going to ask about the estimated date of delivery, or I'm just directly going to ask about how many weeks pregnant you are. Then okay, if I'm not able to remember the question, fine, I know that okay, I need to explore the red flags. What can be the red flags? It can be severe pain, it can be severe nausea, it can be dizziness, it can be palpitations, it can be bleeding, okay, and not feeling any fetal movement can be a red flag, okay. So if you just know the category, okay, then you would be able to automatically recall those questions in your head that okay, this is the red flag. So you don't need to rote learn it that okay, I'm going to rote learn that okay, bleeding is a risk factor, red flag, pain is a red flag, and infection is a red flag. So if you're going to do that, you're not going to like do it as confidently as you're supposed to. Just make sure that the categories are there in your head, and then you have an idea that okay, what are the questions that I need to ask for that particular category. Same goes for the follow-ups and the compliance, basically. That are you taking your medications? Did you get your scans done? Did you get any prenatal testing done? And then talk about infection, that tetanus, torch, rubella. Okay, these are the like, very common things that you think about whenever you think about infections in a pregnancy. Torch infection, tetanus immunization, and rubella, like we have all studied all of these things in our med school as well. We have seen it in our clinical practice as well, okay. So there is no rocket science behind it, but yes, because of the exam pressure, there are like different 12 different questions that I've mentioned over here. You tend to forget a few of them, but as far as you are touching upon the categories, okay, as far as that what are the aspects that I need to have in mind when I'm exploring the current pregnancy, like the duration of pregnancy, the red flags, the medical aspect, the follow up, the scans, and the infectious aspect to it, then automatically and naturally you would be able to come up with at least two to three different questions from each categories, and that would be sufficient for your data gathering. That would be very sufficient to give you an idea how the current pregnancy is going right now, okay, where we are at the pregnancy at this moment. Are there any red flags that I should be aware of? Is there anything wrong that is going in? Is the patient following the nutritional advices? Is the patient up to date with her scans, okay? And are there any infections that I need to make sure that I prevent, so that the baby and the mother is safe, okay? So these four things are going to give you a holistic idea of what the current pregnancy is, okay. And these are like very important set of questions. Write them down in your notes and make sure that you are asking these questions wherever you see someone coming to you for an antenatal visit, okay, whether it's a normal antenatal visit or whether it's an antenatal visit with some complications, okay. Now this particular layer, okay, this is something which is an optional layer, okay, and this is only done when the patient is multigravid and multipara, okay. That means if the patient has had any previous pregnancies as well, okay. So you have to explore the previous pregnancy. But let's suppose if somebody is giving birth for the very first time, then you don't need to get into the details of these questions. But I'll just go through them once so that you have an idea that if somebody multigravid and multipara comes to you got to ask a few questions from this particular category. That okay, how many pregnancies have you had before, okay. Do you have any history of miscarriages, stillbirth, or ectopic pregnancy? Again, this is a bit sensitive question, okay. So make sure that you just signpost, because if somebody has had a history like this, and if you just throw this question directly to them, you're going to trigger their trauma, okay. So just signpost that okay, just a personal question that I would like to ask in order to get a better understanding of your condition. Can you please tell me if there is any history of any miscarriages or any abortions or any stillbirth that you may have had in your previous pregnancy, okay. Word it nicely, okay. Make sure that you are using the right words, make sure that you are using the right tone, all right. Then you got to ask about the mode of the delivery of previous pregnancy, that were they normal labor, were they born with c-section, or was it any assisted delivery, okay. And then just briefly ask about the complications, that did you have any complications after the pregnancy, like preeclampsia, gestational diabetes, postpartum hemorrhage, okay, or did the neonate, okay, or did your child develop any complications after the pregnancy? Like for example, by any chance did your child get admitted to the ICU after getting born? Okay, by any chance did your child have a very low birth weight? Okay, so you gotta make sure that you are covering these aspects when you're talking about the previous pregnancies. Okay, how many pregnancies that you have had, any miscarriages, any stillbirth, what were the mode of the delivery that you had previously, and then the complications, that okay, any history of preeclampsia, gestational diabetes, or by any chance did you go into a postpartum hemorrhage after your delivery? Okay, and how was your child after the birth? Did he have any low weight, or did he or she ended up in a neonatal ICU after the delivery? Okay, so there are 6 to 7 different questions over here. I would at least want you to make sure that you cover at least 2 to 3 different questions, just to make sure that you are giving a hint to the examiner that yes, you know that you have to explore the previous pregnancy. Why? Because the impact of the previous pregnancy also determines the impact that is going to happen in this particular pregnancy. All right, let's suppose if somebody has a history of miscarriage or stillbirth, that means that there is a very strong chance that this patient may develop a miscarriage or stillbirth in this case as well. Okay, if the patient has had previous vaginal deliveries, okay, then this pregnancy is also most likely to be happening from a vaginal delivery. Okay, this delivery is also most likely to happen from the normal labor route. Okay, but if somebody has already had a C-section before, then getting a vaginal delivery after a previous C-section gets a bit difficult. Okay, so the impact of the previous pregnancy, okay, does have some impact that is happening in the current pregnancy as well. Okay, complications. Somebody, if she had preeclampsia in the previous pregnancy, very likely that this patient is going to develop preeclampsia over here as well. Okay, if she developed a postpartum hemorrhage because of placenta previa, placenta accreta, okay, then there is a very strong chance that the patient may develop PPH in this case as well. Okay, so everything is related. Okay, we are not just touching this aspect for the sake of touching it, that okay, since we are exploring this current pregnancy, let's just explore the previous pregnancies as well. No, there is a logic behind it. Okay, and there is a reason why we are asking these questions. Okay, so yeah, some complicated stuff, very detailed stuff, not as simple. There is no mnemonic for it like we had in other cases, like for example, Socrates, Odipara, Flor, Deza, and then for the pediatric history, we had the P bind, and then for the sexual history and for the gynae history, we had the 6 Ps. Okay, so it was like very simple in those cases because you had mnemonics that help you remember stuff. Okay, but in this case, unfortunately, you do not have a lot of mnemonics, and there are different categories, okay, that you need to remember, and there are different set of questions that you need to have: the length, red flags, follow up, vaccination, previous pregnancy. Okay, and each of the categories that I talked about have a bunch of questions that you need to have in your mind. What I can do for you is that I can uh, give you the questions that you want to ask. I can tell you why you need to ask this particular question and how you should be asking this question, but remembering these questions is your job, and making sure that you ask it the right way is something that is dependent on you. Okay, so after you're done with exploring the current pregnancy, exploring the previous pregnancy, then the two aspect of the data gathering is just the previous ones that we've already talked about, that is the PDESA and the MEFTOSA. Okay, and I told you that it usually comes in 2 different cases or 3 different cases: breech delivery and ANC visits. Okay, so yeah, so I told you that there would be 2 cases of pregnancy or breech presentation. One would be 32-week pregnant, and one would be 36-week pregnant. Okay, so in the 36-week pregnant case, you would have to, admit the patient in your care. Why? Because if a breech presentation is there till 36 weeks, it's unlikely to convert into a normal cephalic presentation. Okay, and you would have to do some maneuvers like the extracephalic version, or you may have to go for a C-section, or you may have to check if a normal labor with the breech presentation is possible in this particular woman. Okay, so for 36 weeks, the mode of action and the management approach is that you admit the patient, for further management and for observation. Okay, but let's suppose if a woman is coming to you at 32 weeks and she is having a breech presentation. Okay, you either it's written in the task or you examined the patient. If it's a combined session, you examine the patient and you found out that it's a breech presentation. So for the 32-week pregnant, you're not going to admit the patient at 32 weeks. Why? Because you should have this particular concept in your mind that any pregnancy that is breech before 36 weeks, okay, it has a chance of converting into a cephalic presentation or into a normal presentation before the 36 weeks. Okay, so if you ever encounter any abnormal presentation or the breech presentation before 36 weeks, you gotta wait till 36 weeks to see if it is automatically changing or not. Okay, so in the patient who's coming to you at 32 weeks, you're not going to admit that patient, you're going to just reassure the patient. Okay, and you're just going to reassure and call this patient back for a follow-up after 4 weeks. That means on 36 weeks, and say that okay, right now your baby is in a slightly abnormal position. Okay, which means that the buttocks of the baby are facing your vaginal opening, and the head is present on the upper side, which we call is as the breech presentation, which is not a normal presentation because it makes the chances of a normal labor and the delivery much more complicated. However, what I would like to tell you, Mrs. Smith, that there is a very strong chance that this breech presentation automatically converts into a normal presentation within 4 weeks. So what we're going to do is that we're going to call you up for a follow-up after 4 weeks. That means on the 36th week of your pregnancy, we're going to reassess you and we're going to re-examine you and we're going to see if the presentation has corrected itself or not. And if it's not corrected, then what we're going to do is that we're going to admit you under our observation, and then we're going to perform some scans, some ultrasound, and some few tests that are very important to check the fetal well-being, like the CTG and the fetal heart rate. And under the observation, under that cover, what we're going to do is that experts from our gynae team and our consultant would come and they would perform a procedure that is called the extracephalic version, in which we'll manually try to rotate your tummy so that the baby changes its position back to normal. And if that fails, then unfortunately we may have to go for a C-section. Okay, that is how you're going to manage the 32-week breech presentation. Okay, instead of the 36-week breech presentation. Other than that, there is a variant in which there is just a routine ANC checkup. So you're going to see that everything would be completely all right, and you would just have to give some advices to the patient to make sure that she's not doing any heavy exercises, she's not putting a lot of stress, she's just taking the vitamins, she's just taking the nutritions, she's drinking lots and lots of water. Okay, so just reassurance would be there. Okay, and so I'm just telling you the management very superficially and very briefly. You would have to go and read the notes to understand and to get the all the management pointers. All right, there is another variant of antenatal case, but that comes as a test result station. Okay, so I'm going to I may cover it in the counseling section, in which the test result shows that the patient is having preeclampsia. Okay, so in the data gathering of that particular counseling session, you may have to ask about the current pregnancy. You may have to just ask some aspect of these particular questions that I just highlighted, that I just shaded. Okay, but it's a typically counseling station. It's not a history based station. Okay, like the one that I've shared with you over here. So I'm not not teaching it right now. It is something that I will touch upon in the counseling structures. Okay, so preeclampsia can be one case in which you have to use this information, and routine ENC checkup, you definitely have to use this piece of information, and the breech presentation, you have to use this information. Okay, and one more thing, it can be a pure reading session as well. It can be a combined session as well. Okay, so you got to make sure that you have studied about the steps of the antenatal examination. I'll share a link of the YouTube videos from which you should learn the examination not just antenatal but other examinations as well. So I'll share that link with you guys shortly on my channel. Okay, so that's pretty much it from the antenatal visit and the antenatal history. If you got any questions, then drop them down in the comment box. And if you want to, discuss anything further, if you want to discuss any query, there is a contact number that is written below the QR code. You can reach out to that particular contact number, and we are going to address your concerns. And if you want to take a personalized mock, scan the QR code, visit our website, fill in a Google form, and my team is going to schedule a mock for me depending on the availability. So that's it from my side for this lecture. See you in the next lecture.